Welcome, everyone. This is the Psychedelic Support Monthly Speaker Series. I'm your host, Dr. Allison Fiducia. Today, we have a very special topic to discuss, which is about from destabilization to scientific insights, psychedelic iatrogenic structural dissociation, which I'm really glad Steve Elfrink is here to tell us what this is about, teach me how to pronounce this correctly, and help us to understand how we can navigate psychedelic experiences whenever they become destabilizing or more challenging.
Mhm.
We cover a lot of conversations here about the potential benefits of psychedelics. So it's really great to look at this other side of the picture when things get challenging for folks.
Yes.
So Steve Elfrink is the founder of OmTerra Corporation and a psycholytic somatic integration therapist. He's based in Oregon and is the co-author of a theoretical article on psychedelic iatrogenic structural dissociation, which was published in Frontiers of Psychology. He draws from decades of experience in both personal psychedelic research and clinical practice. Steve is an advocate for trauma-informed, somatically grounded approaches to psychedelic and psycholytic therapy. His work is deeply informed by his own transformative and at times destabilizing personal journey with psychedelic medicines, which continues to fuel his commitment to improving safety, integration, and long-term outcomes for individuals navigating the complex terrain of psychedelic healing.
Cool. So I assume everyone's seen this. You've seen it, Allison, correct? Okay. Well, Allison, again, thank you for the wonderful introduction and all the work you're doing through Psychedelic Support. I think it's a beautiful organization, and I'm honored to be here today. And honored to be reaching out to folks. I know this is going to be kind of a mixed audience of some therapists, also some people who are dealing with destabilization. So I've kind of tried to make this presentation kind of a bridge between the scientific and then just the personal, and for me really reaching out to folks who are going through challenging experiences. So I wanted to, in that kind of vein, I want to start off right off the bat for those who are suffering, for those who are going through any level of destabilization. This really important message of you're not broken, you're not damaged, you didn't mess things up. And the big thing to start to understand is you're having a biological response to your past. And this place of where a younger part of you has awoken. And the big thing to know is integration is possible. And the other big thing is your body is key to get you through this. And also, I'm someone who's been through this destabilization. Mine lasted a year. So someone who understands it from the inside out and just starting to let people know you're not alone. There's got to be more education around this. This is a great start right now today, what we're doing. So I just want to go into a little more about me. So this is just kind of a quick bio. I know a lot of this was covered already by Allison. Currently working as psychedelic or psycholytic somatic integration therapist, which is another mouthful. I'm also a licensed psilocybin facilitator in the state of Oregon, where it's legal. And for me, my practice, about 95% is more of this PSIT process, which is working low-dose ketamine and more of a somatic approach, and not a lot of psilocybin. If I feel like people are ready to go there, we can go there. But a lot of the folks I work with are dealing with complex PTSD, dissociative PTSD, and then also I work with folks who have gone through challenging experiences. So I was also the former co-founder of the Psychedelic Somatic Institute, where they're doing training and more of a psychedelic somatic focused approach to psychedelic therapy. And then for me, but where the crux of my experience comes from, and again, Allison alluded to this, of 45 years experience with psychedelics. And for me, the driving force from that was trying to understand why. And the why for me is like, why was I suicidal? On trigger warning, there will be talk about suicide, abuse throughout this presentation. Nothing gnarly, but it will come up. But for me, that why was I suicidal at age 4? It started very early. And then why was I in a psych ward from suicide attempts? And why was in a drug treatment center? I wasn't alcoholic, but that's where I kind of ended up after another suicide attempt. and then into a halfway house, but I kept trying to understand why. And I didn't subscribe to Western psychiatry, what they were telling me, talk therapy, medication, because none of that seemed to work. So I really became a psychedelic therapy guinea pig, trying pretty much every medicine, every combo. And this photo on the right was, I was actually in a FDA study with psilocybin, a pharmacokinetic study, a true guinea pig, doing, looking at high dose psilocybin, 3 escalating doses over 3 months, which were very challenging. Also, back in the day, underground practitioner, so I learned a lot of what works, what doesn't work through that process. Also, someone diagnosed with severe late onset complex and dissociative PTSD in my 50s. And for me, I'm, yeah, poster child on kind of what can go wrong, but also what can go right. And also this person where psychedelics saved my life and they also nearly killed me. So with that, let's talk a little bit about our hour together. So this will start with a case study, simple case study, someone who went through this. Well, then we're going to talk about what is PISD, and then talk a little bit about the, kind of digging down, going a little deeper into structural dissociation, how the default mode network fits into that. This framework that I've kind of developed that, and all this, everything you're going to hear today, or not everything, but a big portion of it was through learned experience and what made sense and what got me through. What I woke up to was not just, I don't want to go too far ahead, but extreme trauma, extreme complex PTSD. So this dissociative child framework, we're going to talk about screening and symptoms, treatment and recovery, and then some final thoughts. So let's do the proverbial dive in. So the case study is actually me. So this is where the destabilization to insight comes in. So I was an active and happy participant in an ayahuasca retreat. So this is when I was 52, currently 62, so 10 years ago. And as stated, I was a psychedelic evangelist. So I was someone who I had worked with high dose LSD up to like 1600 micrograms, 25 grams of mushrooms, many, many high dose heroic doses, not as bragging rights, but just what I want to demonstrate here is so even if someone has incredible experience, things can still go south, which happened to me. Also, 3 doses with ibogaine, not super familiar for a lot of folks, but a very powerful medicine, probably one of my favorites, lasts about 3 days. Very, very profound. DMT, peyote, ayahuasca before this experience. MDMA, I was a non-responder, which I'm going to touch on a little later. Currently, that's not true. So this was just a classic 3-night ayahuasca ceremony. And for me, the set and setting always important. And my set at the time was, I was really kind of at the top of my game, doing great in life. And then the setting was amongst friends, colleagues, a trained ayahuasquero. It did happen in the States, but a trained ayahuasquero underneath the tutelage of Don Jose Campos, medicine from Don Jose Campos. So it was, 100% kind of the perfect set and setting. So what was interesting for me during the ceremony, it was pretty standard for me, going into these deep, psychedelic experiences and classic snakes going through me, flying over the mountains as a condor, shamanic battles. I mean, it was just not, I mean, it was intense, but manageable. But for me, what happened was after 1 week, that eventually stretched to an entire year. And this was exactly 7 days from the first night of the ceremony, where just out raking my yard in southwest Wisconsin and suddenly felt like, something was coming up again, like, oh, ayahuasca saying hello. And my experience with other medicines, especially ibogaine, sometimes it comes back and says hello. So to me, it wasn't a big deal. So I just sat with it, kind of faded. But then that night, it became just incredibly intense, extreme body discomfort, these painful sensations. Not to be too graphic here, but the only way I can describe it was the experience of being ripped in two, where it felt like my head was going one direction, my body was going the other direction. But then this panic, because not understanding what was happening, why it was happening, and also tied to the extreme pain was just this sense of I'm going to die. And so there was this panic, terror from the pain, from I'm going to die, from what the heck is this? And it was just this total overwhelm of sensations, and felt like it was going insane because it was so intense and so out of the blue. And so what happened is kind of going into the phase two. So like a month in, I started going more into what I know now as depersonalization and derealization. But back then for me, it was I knew I was Steve, but I wasn't sure who Steve was. I knew I was on planet Earth, but I wasn't sure what planet Earth was. Combined with anxiety, sometimes feeling like I was hooked up to a fire hydrant of anxiety. And then these spontaneous, I called them sessions, which could last anywhere from 3 minutes to 8 hours, where I would be just in it in terror, panic, call 911 level. But I was determined not to go to the hospital, determined not to get into a psych ward because I knew that would just be a downward spiral of medication. So this lasted about 9 months. At the 9 month mark, it got worse. It kept getting worse and worse and worse. And I was, yeah, I was not becoming suicidal. I was suicidal at this point. One, the big challenge for me, and this is the most insidious part of people dealing with challenging experiences, or what I went through, was minimal support, and no one knew what to do with me. So this is also a time I was involved pretty intensively with I was doing psychedelic therapy symposiums in the Midwest, and kind of connected with the upper echelon of a lot of psychedelic researchers, and no one knew what to do with me other than don't do psychedelics ever again. Good luck, click. And they just no one knew what to do. So that was one of the bigger challenges, was there was no framework to this. There was no understanding of what I was going through. So out of desperation and survival, I ended up going on Xanax and an SSRI. And the Xanax did help. And I think when people are going through these challenging experiences, there may be a point where meds are necessary. And I was using Xanax, PRN, or as needed when these sessions where the panic would start rising up, and the Xanax would take it down a notch, but it was still pretty awful. But the fascinating thing that happened was the SSRI seemed to be making things worse. So then, and I was just desperate at this point. I'm not a big fan of meds, but I was so desperate. But the doctor switched me to an SNRI, which then led to serotonin syndrome, which I don't recommend. It's one of the most awful experiences. I thought I died. And I've had a lot of awful experiences in my life. That was one of the probably the top five going through that. But the strange thing was it reset my brain. So I went from serotonin syndrome into basically an abatement of those, kind of spontaneous sessions. So stop the depersonalization, derealization was still there, but then that faded out over about 3 months. And this kind of final phase, and that's kind of the phase I'm in right now, is still discovery. But what I found out, the fascinating thing of synchronicity, is after going through this experience is when I ended up in the FDA study with psilocybin, because I knew what I was going through was kind of aborted. Something was there trying to work its way through, but it got stopped. So I wanted to go back in, and I ended up in the psilocybin study. One, I wanted like secure environment. Some people really advise don't do that, but I was confident I'd make it through, and I did. But also at the same time, serendipitously, I learned about birth trauma, because or my personal birth, my birth story, which I had no idea until my 50s, and found out I had this insane birth experience of breech manually flipped by three men. This is back in the early days of um, yeah, bad surgery, bad doctors. But manually flipped by three guys, forceps delivery. The pain was so great for my mom, they had to put her under general anesthesia. And then I was pulled out with forceps by my head, and then umbilical cord around my neck, born APGAR score 2, 0 to 10. 10 is good baby, 0 is pretty much nearly dead baby. So I was pretty rough shape, and then had to be intubated and resuscitated the next day. So I got all this from my birth records. So just this awful birth experience. But what gave me the understanding here was when I heard that, was that experience I had been going through for a year, of being, just literally being ripped in two was this intense forceps delivery. So I was just kind of looping in birth trauma. My body was trying to work through it, and it was just too much too soon. And we're gonna see that as a theme through this conversation, too much too soon. So then also this led to, early childhood abuse because I kept doing more and more sessions and I eventually worked through from a somatic approach through the birth trauma. And the fascinating thing for me, what working through that birth trauma from a somatic approach, the actual experience was about 5 seconds of something that took me out for a year. But just that pain where literally this young infant newborn thought it was going to die. So all of that, and then also all the work I did afterwards of literally doing hundreds of sessions of the somatic focused approach, all led to what we're talking about today. So that's kind of the genesis story of psychedelic iatrogenic structural dissociation. And I threw up this slide because I wanted to make sure I don't forget to mention Lee Bergen, who is the second author for the paper. And Lee's out of University of Exeter, a PhD student and a phenomenal human. And he's the person who really formed this took all my ideas, you know, these concepts, these ideas, these theories, everything I had researched and put it into this cohesive paper that is now published. So PISD, we want to kind of start, now drilling down. Why is this important? So for me, one, someone who's been through challenging experience knows the importance of starting to learn more about this. But for me, I'm a psychedelic advocate. I'm on the cautious side, but full entrenched psychedelic evangelist advocate till the day I die. Again, it saved my life. But what we're seeing is this, the renaissance of psychedelic therapy, this increased awareness, the media hype. We know the, standard medical model, of psychiatry, psychology is somewhat broken, medication's not working. So there's this huge interest, huge promise, and beautiful promise, and then also risk. There is risk with psychedelics. And so for my goal, or one of my goals here is to start highlighting this risk of possible destabilization. We all know about it. Let's start talking about it a little more. But also let's bring in this greater understanding of dissociation, which we're going to talk a lot about today. These trauma-informed frameworks, which are essential for safe implementation. But for me, the most important thing of why PISD matters is this final bullet point of a framework of working through destabilization. Because we're going to see screening, I'll talk about screening, but even in the best screening, the best, set and setting, destabilization can happen. I'm, again, poster child for a lot of this. I was, incredible experience, all da 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 da, and still went into destabilization. So PISD, what is it? So drilling down deeper. So the hard to pronounce, yes, it is hard to pronounce, psychedelic iatrogenic structural dissociation. We're just going to break it down. So psychedelic, we all know as LSD, DMT, ayahuasca, psilocybin, as that's the psychedelic part. The one term a lot of people don't know about, but has definite merit is iatrogenic. And it's basically a Latin for coming from the healer. So it's more common, very common in surgery. So someone goes in for, they have an inflamed appendix, they have appendicitis, they have to have an appendectomy to remove their appendix, but they end up with a staph infection from the surgery. So that staph infection would be iatrogenic. So it was created from the surgery. The intent was to heal, but they created the secondary infection. So that's kind of the genesis of iatrogenic. And then structural dissociation is basically it's a theory around how the psyche fragments. But I want to return a little bit to iatrogenics. I've gotten some pushback on this but it's not harmful because it's doing what psychedelics do, is revealing this kind of the split or revealing this wounded place. But my coming back to that is it is harmful for folks and folks who are going through this know there's harm. I mean, there's also beauty because there's awareness, but I was literally inches away from killing myself. I've had people in my immediate circle who have lost their life from psychedelics, from suicide. So it's, yeah, and I'm not trying to, go kind of hardcore on this, but psychedelics can be risky. They can be destabilizing, and we got to start talking about that. And what happens with PISD is this unintentional, and then the most important thing is this consequential reactivation of dissociated or repressed trauma. So it's where basically we're awakening this inner child. And this creates this split in the psyche. So there's the here and now person, and then also this young child that's emerging, this young part. So, really important, this offers a framework. This is not an official diagnosis yet. So, we're going to keep going down the rabbit hole here. And next is, what is dissociation? So, this is probably one of the more important slides of this whole presentation on understanding dissociation. And for me, dissociation is probably the most misunderstood aspect of mental health, and especially with psychedelic therapy and within the psychedelic therapy community of practitioners. So I think there's just got to be much, much greater understanding of dissociation. So, like everything, dissociation is on a spectrum. So, a psychedelic experience is on a spectrum. Even if someone has complex PTSD, that's on a spectrum. Trauma is on a spectrum. All these different, anything dealing with humans is on a spectrum. So the spectrum of dissociation, everyone would understand this from a sense of if you've ever kind of spaced out, gapped out, kind of even daydreaming, or you're driving in the car and then all of a sudden you're like, whoa, how did I get here? So it can be just a momentary gap of awareness. We just kind of go a little bit spacey. But then that spectrum can be this integrated kind of spaciness, daydreaming, to more on the extreme end, we'd have like dissociative identity disorder where there's a complete fragmentation. So extreme dissociation. And so within that is also complex PTSD. Typically now they're bringing in more around dissociative PTSD, where dissociation is kind of part of the diagnosis or there's more awareness on it, but we got to go deeper with it. And at the heart of dissociation, it's a protective withdrawal. So it's a survival mechanism from our, 250 million years of nervous system development. So it's a protective withdrawal that also creates this kind of fragmented awareness. So a lot of folks who are dealing with dissociation, whether from trauma, it's always going to be from trauma typically, but they can have fragmented awareness where that's kind of like memory gaps. You can be in a conversation with someone with dissociation and like, what? You're talking directly to them and they're kind of just gap out for a little bit. Or you just said something and then 2 minutes later they'll ask you about it. It almost can seem like Alzheimer's to some degree, but it's not. But it's just this fragmented awareness where someone can be dipping in and out of different levels of dissociation. And within dissociation, one of the hallmarks is memory issues because the memory starts to get wiped out with dissociation. So classically rooted in trauma. So this map, we could spend a whole hour just on this map, but we will not spend a whole hour on this. And this massive credit to Eric Walterstorff, who really came up with this map. He was a student of Peter Levine's. Peter Levine was, the somatic experiencing guy, really brought somatic awareness into therapy. Eric took this, this autonomic service system response model, sometimes called the five-state theory, but took it from the work of Peter Levine and just kind of simplified it. But basically, might look a little complicated, but it's really simple as far as fight, flight, and then a lot of people are familiar with fight or flight. And then some people know fight, flight, freeze, but that freeze is dissociation. And this is all survival mechanisms. This is all how we adapt to survive maladaptive environments. So I'm going to go through this a little quick, not giving it the full time, but just there's so much to talk about today, so I got to compress some of this. So you want to start with a state zero. So we've got on the left there activation, across the bottom threat, but a state zero would be a homeostatic state. So this is the body is just normal, and what body seeks is homeostasis. So homeostasis is kind of a normal, stable state. You're at Hawaii, waterfall, maybe a pina colada is involved. and just chill. So zero state, it's chill. It's also simple as body seeks homeostasis with body temperature, 98.6 degrees as our homeostatic state. But as we all know that we can have this place of anxiety. So if there's any situation where there's stress coming in, say you're walking down, left a Broadway play in New York, walking down an alleyway for that shortcut to your hotel and realize this isn't the right alleyway. So this is where it starts to get that activation starts to increase, where you're going to go up to a state 1 of mild anxiety. So that's where there's just a light, a little bit of hypervigilance, mild stress, mild anxiety, fast thinking. Where's the exit? How do I get out of here? Should I call someone? So, but it's not, it's a sustainable, there's that trough there where people can sustain a state 1. Maybe if you live in New York, constant stress, you're always a little bit at a state 1. But what can happen is you're going down that alleyway and then all of a sudden you hear footsteps after you. So now you're going to a state 2, which is more of that fight or flight. So this is high anxiety, high tension, blood flow, boosh, 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 going through you, rapid thinking, got to get out of here. But what can happen is we can sustain a state 1, we can't sustain a state 2. Body can't handle 180 beats per minute nonstop. So what's going to happen, and this is also if, those guys running after that person and now they've got that person tackled down, and the body is going to hit a point of overwhelm. So it can't handle this. The most critical thing here is this overwhelm point, because this is where kind of the curse and the blessing of our nervous system. So what happens at that overwhelm point, a person is flooded with endogenous opioids or naturally occurring opioids. So those opioids are equivalent to about 7 milligrams of morphine. So if you go into the ER, you're going to get, from a bad car accident, chainsaw accident, you're going to get about 7 milligrams of morphine. But what happens, so we go into this shutdown state, and what's going to happen though is everything that happened before and everything that happened kind of after that, overwhelm point of dissociation, flooded with those opioids, the body just keeps recording everything. So this is also, but where memory shuts down and but body keeps recording everything. And so this is also where it's common, someone might say, I walked into my hotel room and then opened the door and there's a person standing there. And then I froze. And then the next thing I know, the police were there. I don't remember what happened. But that's where mind goes offline, but body keeps recording everything. So the key here, though, I was doing an example of an adult going down a street in New York, but we can also put this on a young child. So a young child has even, less defense mechanisms. They can't fight back. They're wired to be trusting of whoever their primary caretaker is. And so also within children, with any of us, there's I mean, sure, this came from, I give someone credit if I could remember who it was, but where some kids are dandelions and some kids are orchids. So some kids are more resilient, some are more sensitive. For me personally, I was a very sensitive kid. So trauma can be, again, on a spectrum. Trauma is incredibly complex. So what affects one child in one way may affect another child in a totally different way. But what can happen to that child, so now if they're in an abusive environment, their system constantly goes into overwhelm. What happens is they start to learn just this dissociative response. It's like, oh, overwhelm, I know what to do. I call it going poof. So they go into this with, it's a protective withdrawal. But again, everything is being recorded. And so in the state of dissociation, it's also this place. So there's two kind of framings here. One, understanding the fight, flight, freeze, but also understanding, like if you're having anxiety in the here and now, if you're going through something like PISD, it's from more of the past. It's a state 2 response. Dissociation, it's really common for people dealing with depression. And if we look at what we call state 3 of hopelessness, but a lot of times endlessness, fear, that can be nausea, suicidality lives in a state 3, misery, and then state 4 into just pure blank emotional, no response, don't feel anything. Kind of that place of anhedonia, no emotions. But what's key here And what happens is all this, everything that has been happening to that child, and again, this can start like for me at birth, it can start the more pre-verbal stuff is a little more gnarly because there's not much delineation of meaning. So, but all this gets tucked away. It all gets just packed down under this lid of dissociation. So this is where I want to segue now, going a little bit deeper into structural dissociation. So the PISD, the structural dissociation part. So this is, for me, when I was going through my destabilization and on my way out, I was trying to find a framework, and structural dissociation theory was the closest thing. And I've also now mutated this a little bit, which I want to go into because I wanted to frame it more what made sense for me when I was going through this. So structural dissociation theory, and the structural is basically where we get parts, we get chunks, different structures form in the psyche. So if we start with an integrated personality before trauma, so this could be, a 7-year-old child who had, great parenting, nurturing, all that great stuff. So a solid child, but then trauma kicks in. It could be a 5-year-old, and again, it could be a 1-year-old or an infant. And then also a trauma, again, it can be neglect, it could be physical abuse, sexual abuse. And there's again the spectrum of trauma. But what will happen is there's the split that happens. This was mentioned earlier, the split in the psyche. And with structural dissociation theory, we're going to have an apparently normal part, which becomes the adult. And then in structural dissociation theory, there's what they call a emotional part, which is basically the child. But this apparently normal part is dissociated from trauma. And they're dissociated because that kid that's, this true source of these emotional responses that are happening kind of lives under this lid of dissociation. So that adult is dissociated from the child, but the child holds the feelings. And then there's this adapted version of the self. So this is also, I've got the side note here, but it's trying to reframe this from pathology to adoption. So basically, we've got to form these identities. There's fortresses, these survival systems to kind of deal with this child that's cleaved off from us, that we don't want to go there because it's so intense. And this is where, like in the IFS world, there's parts. And then within structural dissociation theory, there's primary, secondary, tertiary. So it can get really complicated as far as everything involved to try to hold it together, try to maintain. And so if we go switch over to the emotional part, and for me, this young child, that's where all these somatic memories are. So there's never going to be, this timeline of exactly what happened or a movie of what happened to a child or to anyone, because everything, again, that memory gets shut down. It's all in sensations. So the somatic sensations, body sensations. And then responses needed for survival from that child of fight, flight, freeze. So the anxiety, the depression, the not safe, not safe, not safe, all live within this emotional part or this child. So I want to go deeper. So for me, as someone who's been on the inside of this and is working with IFS, and me as an exile, working, trying the structural dissociation framework. And this is actually not in the paper because couldn't really put it in there because it's all another theory or a different framework. But for me, exile didn't feel right. It didn't fully capture what I was experiencing or going through, that it's just an emotional part. Because my experience as I was going through these different kind of dissociative identities of trauma based on childhood development was there was an actual child there. There was a little Steve there, an infant Steve there, a very, very visceral, real child who was scared out of their mind. So what's fascinating about this dissociative child and where trauma lives is in this place of primary consciousness. And so we have secondary consciousness where we're all kind of operating right now, thinking about what's he talking about? I got to pay the mortgage today, get to that graduation, which I do have to do today. So it's just kind of the basic running of the daily show. But within primary consciousness, which is this pre-reflective, sensory, emotional awareness place, but the key here is what's bolded here of there's no linear sense of time. So it's a place of timelessness. So for that young child that lives in this place of primary consciousness, they don't know the difference from today or from 5 decades ago. So for them, they're just in this constant loop of not safe, not safe, not safe. And that's what the adult is constantly feeling through different levels, sometimes extreme, as in the case of PISD. And then the key is the only way you can't access this, you can't access through cognitive approaches. And then the only way I know through is body. And we're going to be talking more about that as we go deeper. So as we know, this is where I'm drawing from structural dissociation of the trauma-induced fragmentation. But for me, instead of this emotional part, we really think there's this incredible importance of focusing on the child and this actual, what feels like in sessions when I'm working with folks, and even, just complex PTSD, dissociative PTSD, or someone who's dealing with a challenging experience, eventually that child appears, whether it's a 2-year-old, a 3-year-old, a 5-year-old, but they literally can witness this child who is usually looking at them, sometimes with these big googly eyes and kind of like, who are you? But the most beautiful thing is building that bridge between those two. That's part of this process we're going to go into in healing. And also, what's fascinating here in that fragmentation is this, what I call dissociative children. And again, these dissociative children can be based on, or not can be, are based on childhood development. For me, I got to experience the trauma, the dissociation of baby Steve. It was about a 0 to 2, primarily about 0 to 1, and then a really hard, gnarly place of 3 to 5. But each one of these, you know, dissociative children had their own levels of dissociation and then their own trauma. So within this is this place of enduring, again, kind of touched on this, but that somatic memory that holds everything that the body's been dealing with as far as, the depression, anxiety, mental health symptoms, all emerging from this dissociated child. And then part of the healing is compassionate integration, this place of what I call withness, and also bringing in more of this concept of self within IFS framework. And this could be an hour presentation on this, just diving deeper into this, but enabling reintegration. And then the beautiful thing, since this child lives in this timeless place of primary consciousness, that attachment can be formed because attachment lives in primary consciousness too. So for me, it's a lot about building the bridge between the adult and self to that dissociative child. And then as this place of withness, staying with through some of these emotionally challenging places, where eventually that dissociative child bonds to self, bonds to that adult. And that's where I've seen the biggest drops in myself and folks I work with when they go through that kind of reconnection, that attachment that just kind of starts to happen spontaneously. But the key to recovery is connecting with this child that lives within you. But a lot of folks say, well, I don't have trauma. Nothing bad happened in my life. So this is a common thing I hear. And the big thing to know, trauma isn't always visible or consciously remembered. Because again, your memory just gets whoosh, shut down. Body keeps remembering everything. But that's where this anxiety that keeps showing up, this feeling of disconnection where you're a group of people, but you feel separate from the depression that kicks in, takes you out. This is all that child. This is trauma talking. Your mind forgets, but your body doesn't. So I kind of said this one already, but early overwhelming experiences leave hidden imprints and then surfacing as this depression, anxiety, emotional confusion. And then the key here is also so frightening and awful, this emergence of this child, of this place, is probably the biggest opportunity for deep healing. And it's basically to rescue that child. And again, I don't want to minimize this because I know for folks going through this, it's awful and it's overwhelming and it's confusing, but also there is a way through this. So I want to go back to, oh, I got to speed up a little bit here. Back to PISD fundamentals. So what happens? So let's kind of recap, but trauma unmasks too fast, spontaneous structural dissociation activation of the emotional part, or what I call the dissociative child. And then within this is a spectrum of challenging experiences. It can be just in a really, really hard, session or a psychedelic ceremony experience. But after the really intense place, you come out of it and you're okay. Or it can be you come out of it and you're wiped out for a few days, or it comes out of it and you're wiped out for 10 years, 4 years. That's some of the folks I've had to work with, or sometimes it can be long term. So again, there's a spectrum of these challenging experiences. And then how does this happen? So again, this is a theoretical framework, but to me, what makes the most sense and just kind of nails it, basically how this happens is basically it's triggered by a default mode network collapse. So default mode network, very popular and talking about psychedelic therapy right now. And the beautiful thing about psychedelics, they kind of dissolve the default mode network, allow us to go into unity consciousness, white light, we're all one, that beautiful sense of unity. But it also is this place that underpins our sense of self, identity, internal narratives, our internal story of who I am, social cognition. And what can happen is psychedelics can overwhelm the psyche, triggering the dissociative symptoms, intense anxiety, or existential distress. Basically, that dissolving of the default mode network can take someone into the heights of heaven or break down this incredible fortress, this incredible, um, I guess the best way to describe it is a fortress, but defense mechanisms that apparently normal person has developed to not go there. So that gets wiped out. And then this child emerges, and then that's what we're dealing with is this, literally the person is hijacked by a 3-year-old or a 5-year-old who's scared out of their mind. So these are some of the classic symptoms. I actually reduced this down to two, or it was 2 slides. I got it down to 1 slide because it can be pretty severe, pretty extreme. But a lot of folks will be experiencing psychosomatic symptoms, tight chest, shaking. That was a big thing for me. I would just it was almost like I was having a convulsion. The shaking would be so bad. A numbness, digestive issues. There can be like micro tremors. There can be muscle spasms. There can be jaw pain. I mean, it can go on and on and on. And then this just difficulty of regulating emotions. And that's common. I may have mentioned this. So just feeling hijacked or swept away. I was fine. And then all of a sudden, whoosh, I felt like a wave just took over me. And I just didn't know who I was or what I was or what was going on. But it was just pure anxiety, pure terror out of the blue. And it's just this hijacked place. And then feelings of being somewhat stuck in the psychedelic experience, not can't return to baseline, don't even know what baseline is anymore. Lost to trust in oneself, the world, therapeutic spiritual paths. But it's also, again, the big thing to know here is all this is basically what it boils down to is you have an adult and you have a child. And we have the adult with their set of eyes, but now you have a child who's awoken looking through that same set of eyes. So that child doesn't trust anyone because he doesn't know where they are. Nothing makes sense. And then there's this adult trying to make sense of something that normally would make sense. Normally, I'm in a business meeting and I'm not freaking out. Right now, I'm freaking out. But it's also this child kind of awakens. So it's this very, very confusing place when you've got a 3-year-old and a 55-year-old trying to navigate life. And there also can be a re-traumatization during integration attempts of therapy. So if someone's kind of coming in too fast, too hard, trying to fix something, it can be overwhelming because now you're trying to fix a 3-year-old, and the 3-year-old's going, not safe, not safe, not safe, too much. So you can kind of just trigger more dissociation. And then just avoidance of the internal experience. So numbing, trying to get away, basically trying to get away. Substance use, excessive distraction, but trying to get away from all that emotional angst and fear and panic and terror. Suicidal ideation is common in the sense of a psychic death without resolution. This place of hopeless and endless, but again, back to that map, a state 3 experience. And again, all this is looking through, you got 4 eyes looking through a set of 2 eyes. And my experience with this is also personal from working with folks. The intensity of these symptoms seem to be more intense with earlier trauma, especially pre-verbal is the most confused, the most chaotic for folks if it's pre-verbal. So screening, so I'm going to go a little bit faster on this one because I do want to make sure we have time for questions. So deep dive into trauma history, and that's natural, normal for folks that'll minimize their past. There's denial, there's avoidance. They don't want to talk about it. And it's not even conscious to not talk about it, but it's just, they don't want to go there. So it's so common where, ask someone about trauma history, what about childhood? I'll be like, oh, it wasn't bad. It was pretty good. But this thing happened when I was 17. Well, what about your childhood? Well, no, not much. And then, but keep going a little deeper. And then, well, dad was an alcoholic. And then, da 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 da. But I probably deserved it. So there's a lot of minimization, a lot of denial, or not even bringing it up. So it's really important to kind of really not to push, but to explore. And a huge one for me is previous challenging experiences, especially with cannabis. Cannabis is probably the one of the most effective medicines, in sometimes a good way and sometimes in a bad way, of breaking through dissociation and into what I call a trauma ball or into that dissociative child. So I was one of those people who smoked a lot of weed, and then all of a sudden, the cannabis turned on me, and also had a pretty much a psychotic break from cannabis where I, hindsight, I know now it was birth trauma, but it felt like someone was trying to kill me. I was going to die. My head felt like it was being crushed, felt like my eyes were going to come out of my head. But where the cannabis popped me into that dissociative child. Excuse me. So previous challenging experiences, also if they've had previous challenging experiences with any psychedelic, go deeper. Start to understand that. What did it look like? And then another one is a non-responder to psychedelics. Like I mentioned earlier, I was a non-responder to MDMA. So this is also where there's a spectrum of response to psychedelics. One is a non-responder. But if someone has a ton of dissociation in their system, like I did, from extreme trauma, we learn if there's a kind of a stress response, we know what to do. We go poof. We flood the body with these opioids. So for me, I could take MDMA and do the 120 milligrams, 50 milligram booster with friends, with in a therapeutic setting, with sitters, headphones, eye shades, male, female, and I would just be blank, numb, take the booster, more blank. So, but it was just hitting this wall of dissociation. I was trying to really protect myself more than anything. So for me, with practitioners, and there's probably a little controversy on this, but I say don't updose if someone's not responding. I know if people are on SSRIs, sometimes you got to bump it up, but be careful because what you don't want to do is go through, break through that wall of dissociation and get into where too much too soon. And then another one is the DS2, a dissociative experiences scale that some people bring in. For me, I keep it more to the interview of really getting to know the person. And I'm not going to go through all these, but just for some pre-screening questions, this disconnection from self or body, what we're kind of doing is fishing out for dissociation, memory gaps, time loss, internal conflicts or parts that kind of want to do this, don't want to do this, but kind of at an extreme level. A big one is emotional numbing overwhelm and this trigger trauma response where people, like for me, hindsight is so valuable, but not at the time. Where with, like my ex-wife, where she'd be a little bit upset, not even upset, but like, hey, you left the water glass out again. No, not a raised voice or anything, but just anyone upset for me would equal death. And so a little bit of upset, they're not even upset, but the way I would interpret it was I'm going to die. And so I called it going poof or into the mud, where I just go into this dissociative wave. Didn't know anything about dissociation, but I could be la-di-da, someone's remotely upset with me, and I would go into collapse. So that's also another key indicator of dissociation. And just altered perceptions, identity confusion. But for me, a big one is always if you're in a group of people but feel not part of. So the road back, I'm going to go through this one. Um, but I've touched on some of this. And the most important thing out of all this, probably point number two, as far as validate and normalize the experience. And for me, that, how I started this whole presentation is you're having a biological response from trauma from your past. And these are normal, understandable, not signs of going crazy. This is your body trying to just get back to homeostasis. It's trying to like work things out. You're not crazy. You're not insane. You don't have a mental health issue. So this is normal. And that's where, again, we got to get from pathology to adaptation as far as you had to adapt to a stressful environment. You discovered dissociation. It got packed away. So the other important thing is really bringing in strengthening the adult self and also the concept of self. So grounding practices, breath work. And then for me, the only way to really get through this, because you can't talk your way through PISD, you can't do more psychedelics, especially big psychedelics, but a body-focused, trauma-informed approach. IFS is beautiful, and this dissociative child work. But it's really, really, really important to have a somatic focus to this, because what we eventually have to do is get to that young child, let them feel everything. Go slow. I always tell my clients the fastest way you're going to get through this is to slow down. Because one, again, a lot of times we're dealing with this 3-year-old. They go slow. They get overwhelmed. They're already overwhelmed. So we got to bring everything down to match where they're at. And as much as possible, limiting the here and now stress. And then, so just the cup runneth over. So as much as possible to kind of like, I call it sometimes go into cave bear mode and just kind of hunker down and start being with that little one, being with these emotions, this place of this wounded child, and then gradual integration and support. Art therapy is huge in this, to start drawing this out, drawing out these feelings, these sensations. And the biggest thing is connecting with body. And then this is the process I work with. Um, Again, mentioned before, psycholytic somatic integration therapy. And this is evolution from Peter Levine, Eric Walterstorff, Saj Razvi, Jen Pfizer, um, the Sematic Institute where I used to work, where we had PSIP, psychedelic somatic interactional psychotherapy. And then as everything evolves and what I found didn't work with PSIP, what worked, outside of that is kind of the framework of what I call PSIP. But again, it's just this body focused process to activate the autonomic nervous system, to release the held trauma, reactivity, the sensations, the pain. And for me, the important thing in all this work, if you're working with someone who's going through a challenging experience, go with psycholytic or low dose. Don't try the 5 grams of mushrooms with those folks. Because what you're kind of doing is giving 5 grams to a 3-year-old or a 2-year-old or a baby, especially if they're in a really destabilized place. Low doses, when I'm talking, I use troches 30 or 60, 30 to 60 milligrams. So we're only going about 18 to 20, maybe 25 milligrams of actual ketamine. Original PSIP model was very focused on cannabis, but cannabis, again, can be too much too soon. It activates 3 trauma centers. It'll go in, but we don't want to go in fast. We want to go in slow. And what we're trying to do is move through the dissociation into activation and then release. And that's the key, is allowing that child to unburden themselves, to just feel the terror, feel the panic, but in a safe environment where it's contained, controlled, and moved out in these little waves. And then for me, the other huge important thing is bringing in the strong framework around the dissociative child, or the emotional part. But strong focus again on seeing the split as a real live child, and then working towards integrating that child. And this is what every day when I'm working with a client, at some point it's going to come up about, we're coming home to body. Body is now safe. And so that coming home to body is coming home to the child, all these parts, and reintegrating all those. And then the importance of the relational container, my relationship with the client, building safety and trust with the adult, and more importantly, is with that dissociative child who doesn't trust anyone and is freaked out. So I got to go really fast. Sorry if this has gone longer than expected. But practitioners, final words: slow down, more careful intake process, further education into understanding dissociation. Bigger's not necessarily better. Consider psycholytic dosing as an entry point to test the waters. If you have someone like, well, kind of an intense trauma history, and also I recognize a lot of people have worked with people with trauma and there was no problem and it actually helped them. I get that. But I just, a voice of caution and nuance and testing the water sometimes. And a big one for me is also this final point, to reevaluate the assumption that the medicine always knows, especially in cases involving early trauma. And always, again, the tricky thing is you're not going to know sometimes if there's early trauma. But yeah, a little less, I think, overall for the psychedelic community, less cavalier, a little more cautious. And again, I'm not trashing what we're doing. There's beautiful work out there. But for me, as someone who's been through it, let's be careful. And then the folks with destabilization kind of said this, I want to say it again, you're not crazy, it's biology. not mental illness, or you're not broken. Find your ground, your breath. Where are these sensations in body? Because mind's going to be going, body's going, give it to me, I can handle this. So start feeling into body. Where's anxiety? Where's that terror? Where's the panic? And some of that's coming safe to come home to body, to that child. Your body's your way back. Get support. And the biggest thing is you got this. Everything you need to get through, if you're dealing with this, you have, because you have body, you already have this sense of self that's in there. We want to strengthen that. But the key through is body, body, body. But most importantly, thank you. Thank you for enduring this. I shouldn't say enduring, but thank you for hanging in there with me. I'm sorry we're going to have limited time for questions. But this is my contact info. Again, my name's Steve Elfrink. OmTerra is my company that I work for. Email, feel free to reach out to me, steve@omterra.org. I am in the process of forming a PISD support group. So this is for folks who are going through destabilized experiences, and looking at workshop, and then also just a support group for those folks. So we've got a big 3 minutes for questions. Sorry,
Yeah.
Allison, this went long, but
No, no need to apologize. This was really interesting. I learned quite a bit. So thank you for your knowledge and sharing your personal story. And I just wanted to acknowledge that several people in the chat uh, really felt that they had experienced a similar situation as you had. So this maybe is not as uncommon as some may think. And I appreciate the conversations and the openness to understand how we can support others and potentially know how to navigate these situations in more held ways. So with that, we do have time maybe for like one question.
and
So I'm
then
just,
Allison, sorry to interrupt you, but one thing I can do and be totally willing to do, if you supply the questions to me, I could do a video answering all the questions. And we can do one
okay.
today, but I would be happy to follow up with folks in any way possible to answer all their questions.
Okay, great. Yeah, we will share. I can share the chat with you too, because there was some interesting conversations happening there too on the side and resources
Awesome.
shared. So, um, yeah, there are plenty of questions here. I think I'll go with Kylia's. She is asking, is it psychedelics or the lack of right conditions for clients that can be harmful? Are we missing some right conditions even when what people usually consider the right standards for set and setting are in place? And essentially, the question here is, what's the difference in your view between PISD and spiritual emergency?
Let me start with, so I think even in the perfect set and setting, the perfect container, like my experience with my ayahuasca ceremony, perfect. I mean, it was trusted friends, my homies, colleagues, and everything was perfect. And this is the kind of the sometimes the roulette of psychedelics. Yeah, I didn't see that coming. No one that was, part of that group saw that coming. So I think even in the kind of repeating myself, but even in the perfect set and setting, um, things can go south. And that's where, for me, the importance is, okay, we can't perfect set and setting, we can't perfect screening, but let's perfect and better understand how to hope, or how to bring hope and help to people who are destabilized. And then how does this compare different from spiritual emergency? For me, there's a big difference in the sense of, spiritual emergency can also sometimes bleed into possibly PISD. Is it spiritual emergency or is it PISD? But I think within that framework of spiritual emergency, usually it's more like around existential crisis, or I've saw God, now what do I do? And it's a lot of times the spiritual emergency is less somatic and more identity confusion, existential crisis. And PISD is more of this just taken out, hijacked. I think there's younger emotional parts that just give a different flavor to it. And if that makes sense or helps, but that's what I got.
Yeah, yeah, this is great. Thank you. And, writing the publication about your theory and seeing it now on the slides, it's helpful for practitioners and others to have a way of understanding when these arise for their clients and how to support them. So I really applaud your work. I
Thank you.
appreciate you so much for being here, and everybody that attended. Just by the number of people that showed up today, I can tell that this is on a lot of people's minds. So let's keep the
Beautiful.
conversations going, and we'll share the video after along with the resources by email, and then we also post it online. So
Awesome.
more to come.
Thank you so much, Allison. And thank you to all the folks out there who participated by listening today. And again, if you're suffering from this, there is help, there is a way through. Yeah, you're not broken. So
Mhm.
please, please, please hang in there.
Yeah, very
And have
important.
everyone have a beautiful weekend.
Yeah, have a great weekend, everybody.
Okay.
Take care.
Bye-bye.